Alcoholic liver disease. I have no financial disclosures. Objectives: comprehend the impact of alcoholic liver disease in the United States. List risk factors for liver disease progression. Describe history and physical findings in alcohol use disorders and alcoholic liver disease. Summarize the radiologic and biochemical workup. Identify the at-risk drinker for whom intervention is indicated. Outline the management of patients with alcoholic liver disease. Let's begin with some definitions. One standard drink or serving size is 12 grams of alcohol. There are 12 grams of alcohol in 12 ounces of beer, or 5 ounces of wine, or a jigger of spirits. The National Institute of Alcohol Abuse and Alcoholism defines at-risk drinking as more than 4 drinks per day or more than 14 drinks per week for men, and more than 3 drinks per day or more than 7 drinks per week for women. Binge drinking is equal to 5 or more drinks within 2 hours for men, 4 or more drinks within 2 hours for women. Alcohol and liver disease. Alcohol is a legal and socially accepted hepatotoxin. Alcoholic liver disease is the second most common reason for liver transplantation in the United States. Alcohol use can affect newborns, children of alcoholic parents, adolescents who are experimenting, college students who are victims of alcohol poisoning, pregnant women, adults, the elderly, and innocent bystanders who are injured in automobile accidents caused by drunk drivers worldwide. Some statistics: 1 in 10 deaths in the United States are attributed to excessive drinking. About 88,000 alcohol-related deaths in the United States and $224 billion in economic costs were incurred between the years 2006 and 2010. Between 2010 and 2012, there were 6 alcohol poisoning deaths each day in the United States. We have about 30 million veterans in the United States, and the old adage goes, real soldiers can hold their liquor. There were about 58,000 admissions to non-VA substance abuse facilities in 2010, and veterans identified alcohol as their primary substance of abuse. The number of soldiers in treatment increased by 56% between 2003, when the Iraq War began, and 2009. 1 in 8 troops returning from Iraq and Afghanistan between 2006 and 2008 were referred for alcohol counseling. Alcohol use disorders are under-recognized and under-treated. Formerly called Alcohol Abuse and Alcoholism in the Diagnostic and Statistic Manual of Mental Disorders 4, there is now a change in terminology with the DSM-5 to alcohol use disorders with mild, moderate, and severe subclassifications. The U.S. Preventive Services Task Force recommends alcohol screening for alcohol use disorders and conducting a brief counseling intervention in at-risk individuals. But is it discussed by healthcare providers? The MMWR conducted a survey in 2011 of 166,753 adults. Their conclusions were that only 1 of 6 adults, including binge drinkers, who reported ever having discussed alcohol consumption with a healthcare professional. So what are the alcohol-mediated hepatotoxicity risk factors? First, dose and duration. Life volume of ingestion is the most important predictor of liver injury, but interestingly, only 6% to 41% develop cirrhosis. Drinking as much as 14 drinks a day for 10 years or 7 drinks a day for 20 years can lead to significant liver injury. The drinking pattern is a second risk factor. Binge drinking is just as harmful as drinking on a daily basis. Drinking on an empty stomach increases the risk of alcoholic liver disease by 2.7-fold. There are genetic factors: obesity and overweight, continued drinking in the setting of known liver disease. Gender: females are twice as sensitive to alcohol-mediated liver injury and more severe hepatotoxicity at lower dose and for shorter duration compared to males. Ethnicity, rates of cirrhosis are higher in blacks and Hispanics compared to Caucasians. Hepatic iron deposition, such as in hemochromatosis, viral hepatitis B or hepatitis C, and concomitant drug ingestion with alcohol, such as acetaminophen, are well documented factors. What is the spectrum of injury from alcohol? Steatosis occurs even in non-regular drinking individuals who drink heavily, and it is reversible with abstinence. Acute alcohol hepatitis affects 10 to 35% of hospitalized adults. It is associated with high mortality and may not be reversible. Symptoms include leukocytosis, abdominal pain, jaundice, anorexia, nausea, vomiting, diarrhea, weight loss, and ascites. Finally, chronic hepatitis leads to perivenular fibrosis, which in turn leads to cirrhosis, decompensation, or hepatocellular carcinoma with liver transplantation or premature death. Alcoholism. There are 8 million alcoholics in the United States. Abuse is defined as those who suffer social and health consequences, accidents, loss of family or job, and continued drinking. Dependence is the syndrome of development of tolerance and withdrawal. And 3.81% of the population met the DSM-4 criteria for alcohol dependence. There were 500,000 episodes a year of withdrawal serious enough to warrant pharmacotherapy. Symptoms of alcohol withdrawal begin within 8 hours of the last consumption and include insomnia, anxiety, increased temperature, heart rate, respiratory rate, and blood pressure, as well as hand tremor. They peak at around 72 hours and are reduced by day 5 through 7 of abstinence. Mild symptoms include nervousness, anxiety, irritability, mood swings, depression, and fatigue. Moderate progressive cephalgia, sweaty palms and face, anorexia, nausea, vomiting, insomnia, palpitations and tachycardia. On exam, you'll see dilated pupils and pallor. Severe withdrawal is exhibited by confusion, agitation, hallucinations, fever, history of blackouts, and seizures. Severe withdrawal requires hospitalization for intravenous fluids, nutritional support, benzodiazepines, and in hospitals, the CWA protocol is commonly used to score the severity of the symptoms. The workup begins with taking a good history. First, ask the patient the simple question, do you drink alcohol? Quantify the number of drinks per day for the number of days per week for X number of years. Ask, have you ever had a fall resulting in a fracture or other traumatic injury? Were you ever in rehab? Did you ever lose a relationship or a job? The CAGE questionnaire is very effective. Have you ever thought of cutting down? Have you become annoyed when people ask you about drinking? Ever feel guilty or need an eye-opener? 2 out of 4 positive responses has a sensitivity of 71% and a specificity of 90%. The Alcohol Use Disorders Identification Test is a simple screening tool that can be done by nurses and is included in the CPRS nursing reminders. Workup. The physical exam is often normal or very subtle findings. In more advanced disease, you may see diffuse muscle wasting, scleral icterus or jaundice, vascular spiders or telangiectasia, often on the upper neck, sometimes on the arms. In men, gynecomastia or testicular atrophy. In the abdominal exam may show a nodular, shrunken right hepatic lobe and an easily palpated, hypertrophied left lobe, typically 2 centimeters below the xiphoid. Splenomegaly may be present, ascites, peripheral edema, and on neurologic exam, a positive Ronberg, slowed cognition, or asterixis may be detected. The workup using imaging, complete abdominal ultrasound is an excellent tool to evaluate for hepatic steatosis, a nodular liver margin, mass, or evidence of portal hypertension. seen by splenomegaly with a normal spleen being 5 to 12 centimeters, collateral veins surrounding the esophagus, recanalization of the umbilical vein, or ascites. Chemistries, the AST is usually greater than the ALT in a ratio of 2 to 1 or 3 to 1. Gamma-glutamyl-transferase, or the GGT, is a nonspecific test and is insensitive but is often elevated after alcohol consumption. I order a GGT in the setting of increased alkaline phosphatase to separate if the alk phos is coming from bone or from the liver. The GGT is an independent predictor of sustained virologic response in the treatment of chronic hepatitis C. Early thrombocytopenia, late finding is pancytopenia. Prolonged prothrombin time is also a late sign, as is hyponatremia, hypoalbuminemia, hyperbilirubinemia, and hyperferritinemia, the latter due to heparin suppression from alcohol toxicity. Alcoholic liver disease is a multi-system disorder with alcohol neurotoxicity. Wernicke-Korsakoff is a result of thiamine deficiency, appears as memory loss, confabulation, hallucinations, and ataxia. Long axon nerve fiber injury is often discovered when the patient complains of painful sensory neuropathy. Fatal and non-fatal accidental injuries have occurred. Cardiomyopathy, hypertension. When you have hypertension that is being treated with multi medications but still elevated, suspect occult alcohol use. Malnutrition exhibited by weight loss and weakness. Vitamin deficiencies such as vitamin B12, thiamine, folic acid, niacin, vitamin D. Pancreatic insufficiency or pancreatitis, and cancers of the mouth, throat, larynx, esophagus, and liver. The diagnosis of alcohol use disorders begins with quantification of the dose, frequency, and pattern of alcohol consumption to identify the at-risk drinker. Then evaluate for the presence of dependence or abuse. Exceeding recommended safe limits or drinking in the presence of adverse events establishes diagnosis. Expert history and physical will direct testing for evidence of alcoholic disease. The management of alcohol use disorders begins with an annual screening test, conducting a brief intervention for the at-risk individual. I tell my patient he or she is drinking more than is medically safe, determine if he is ready to modify his drinking habits, and if so, recommend cutting down with specific goals or ways to do so, or else advise total abstinence. If the patient is not ready to stop drinking, have the discussion at the next appointment. Also, if ready, refer to substance abuse disorders rehab and counseling. The VA offers treatments that include ways to increase and clarify the veteran's motivation for change, help the veteran improve skills for recognizing and dealing with triggers and relapse risks, counseling regarding how to recover from substance use disorders and improve relationships, looking at how substance use problems may relate to other disorders such as PTSD and depression, and getting outside recovery support through Alcoholics Anonymous, religious organizations, or social workers. Management with pharmacotherapy. There are options for anti-craving drugs when cirrhosis is not present, including Antabuse, 250 milligrams a day, naltrexone, 50 milligrams daily, or the monthly extended-release injection, and Camprol, 666 milligrams TID. In the setting of cirrhosis, the options are limited, but one study found baclofen effective. So assess for protein-calorie malnutrition, suggest a diet high in fruits and vegetables with small portions of meat and plenty of legumes, nuts, dairy products, fish, and poultry. Bone health is important. Chronic liver disease is associated with vitamin D insufficiency and deficiency as well as osteoporosis. So check a 25-hydroxyvitamin D and replace as indicated. Check a baseline DEXA scan. Supplement B vitamins and consider a once-daily multivitamin. In conclusion, Excessive alcohol drinking takes 1 in 10 American lives each year. Screen all your patients as part of the annual exam. Use the CPRS reminder. An expert history and physical examination is useful to point out to the patient physical effects of excessive drinking and help motivate for change. Provide brief counseling intervention and to drink within safe limits, abstain. Managing those with chronic liver disease includes treating nutritional deficiencies, vaccinating for hepatitis A and B, referral for substance abuse, and referral to a hepatologist if there is cirrhosis or advanced liver disease. Thank you.